You think insurance exists to protect you? It doesn't. It exists to manage cost exposure, to convert your suffering into predictable revenue, to transform pain into a line item that can be modeled, delayed, and denied. This is the medical historian, where medicine, history, and power collide. Because insurance denial isn't just frustration, it's the business model. Every prior authorization, every claim rejection, every month your premiums sit invested before a single approval. All of it rests on an invisible scaffolding of profit, leverage, and extraction. To see how we got here, not to the ACA, not to managed care, but to the origin, when insurance was invented to shield people from financial ruin, not to engineer it, go back to 1929. Dallas, Texas, the Great Depression. Baylor University Hospital is collapsing, not because the doctors aren't skilled, not because the hospital is poorly run, but because patients can't afford to pay. Justin Ford Kimball, vice president of Baylor's hospital system, sees a crisis, and he has an idea. What if patients prepaid for care, 50 cents a month? In exchange, you get up to 21 days of hospital coverage per year. He pitches it to Dallas school teachers first. They sign up immediately. Within months, thousands enroll. The model spreads like wildfire. They call it Blue Cross. By 1939, 3 million Americans are covered. By 1945, 20 million. But here's what matters. Blue Cross wasn't designed to profit from denying claims. It was designed to collect premiums and pay claims. The math was simple. Collect enough to cover actual hospital costs, add a modest buffer for administration, pay the bills when people get sick. The mission was protection, full stop. There was no profit motive to delay care, no incentive to define medical necessity narrowly, no armies of utilization reviewers looking for reasons to say no. The healthier the population, the more efficiently the system ran. Blue Cross succeeded when patients stayed well and got care when they were sick. Insurance worked because it was designed to work. This is crucial, because it proves something uncomfortable. Insurance didn't have to become what it is today. The problem isn't insurance itself. The problem is what happened next. After World War II, something shifted. Healthcare costs started rising. New technologies, new drugs, more sophisticated surgeries. The system was expanding, and insurance companies realized something. They didn't have to be nonprofits tied to communities. They could be for-profit corporations. They could go public. They could generate shareholder returns. Aetna, Cigna, Prudential. These companies entered healthcare not because they wanted to help people. They entered because they saw a revenue stream. But here's the problem. As a for-profit insurer, you face a fundamental conflict. Your shareholders don't want you maximizing patient outcomes. They want you maximizing profit margins. The solution? Redesign how insurance works. Instead of aligning incentives toward care, align them toward cost containment. In 1958, economist Paul Elwood presents a radical idea to insurance companies. What if you paid providers a fixed amount per patient, regardless of how much care they provided? Capitation. Under capitation, the provider keeps whatever money isn't spent on care. The less treatment you provide, the more profit you make. This is revolutionary. This inverts the entire incentive structure. Before capitation, more care equals more cost. The insurer profits only if premiums exceed payouts. After capitation, more care equals less profit. The provider profits only if patients don't use services. All the incentives are now toward less medical care. Insurance companies love this. By the 1960s, capitated plans are spreading rapidly. The architecture of extraction is being built. Now go to February 17th, 1971. The Oval Office. President Richard Nixon is meeting with his domestic policy advisor, John Ehrlichman. Healthcare costs are rising. Senator Ted Kennedy is pushing for national health insurance, what conservatives call socialized medicine. Nixon needs a private sector alternative. Ehrlichman pitches him on health maintenance organizations, HMOs, capitated plans, for-profit entities. Here's the exact conversation captured on White House tapes. Ehrlichman says, Edgar Kaiser is running his Permanente deal for profit, and the reason he can do it is all the incentives are toward less medical care. The less care they give them, the more money they make. Nixon responds, fine. Read that again. The less care they give, the more money they make. And Nixon's response, fine. That moment, that conversation, that's when the trap was designed. December 29th, 1973, Nixon signs the Health Maintenance Organization Act. The act authorizes federal grants to develop HMOs, requires large employers to offer HMO plans, removes state restrictions on for-profit healthcare, and establishes health maintenance as an economic model, not a care model. The stated goal? Control costs through preventive care and coordination. The actual goal? Create a system where denying care is profitable. By 1985, over 20 million Americans are enrolled in HMOs. The architecture is in place. By the late 1980s, the for-profit insurance model is established, but profit margins are still modest. Then comes 1993. The Clinton administration pushes healthcare reform. The insurance industry sees an opening. If we improve efficiency, they argue, we can justify higher margins, better technology, better data, better predictive models. In 1995, United Health Group develops Optum, a data company. It begins collecting medical records, claims history, medication data. By 2000, Optum has data on 100 million Americans. For the first time, insurers have the ability to predict which patients will be expensive. They use this data to redirect care to cheaper options, deny expensive treatments preemptively, funnel patients toward cost-minimizing pathways. Optum isn't a healthcare company, it's a predictive extraction engine. Then comes 1997. Congress creates Medicare Advantage, privatized Medicare. The pitch? Private competition will lower costs. The reality? Private insurers receive higher payments from Medicare than traditional Medicare costs. They cherry-pick healthier seniors. They deny care aggressively. By 2023, 31 million Medicare beneficiaries, over half the Medicare population, are in privatized plans owned by United Health, Humana, and Anthem. These companies have one incentive: deny expensive care to maximize profit. Now add AI. By 2020, insurance companies are using algorithms to make medical decisions. Cigna's PXDX algorithm denies claims automatically. Physicians spend an average of 1.2 seconds reviewing each claim. 1.2 seconds. That's not medical judgment. That's algorithmic rejection. Another algorithm, NH-Predict, denies post-acute care. It has a 90% error rate. 9 out of 10 denials are wrong, but only 0.2% of patients appeal. The insurer knows the denials are wrong. They're counting on patients not knowing enough to fight back. This is calculated deception. Fast forward to today, let's look at how the trap actually functions. The mathematical structure of it. You pay premiums monthly. $300, $400, $600, doesn't matter. The insurer collects before you're sick. That premium money is immediately invested in bonds, in stocks. It generates returns. If the average patient doesn't use healthcare for 6 months, that's 6 months of float, free money the insurer earns returns on while delaying claims. The insurer needs to minimize payouts, so it designs systems to prevent claims from even being submitted. Narrow networks. Doctors only get paid if they're in network. Most people won't drive 45 minutes to find an out-of-network provider. The network shrinks choice without denying access, high deductibles. Before insurance pays anything, you pay $1,000, $2,000, $5,000 out of pocket. Many people never meet their deductible. They file no claims. The premium is collected. No payout occurs. Formularies. The insurer maintains a list of approved drugs, ranked by cost. Your doctor prescribes drug A. The formulary covers drug B, cheaper. To get drug A, you need prior authorization. Time becomes the tool. Prior authorization is where the trap becomes visible. You need a procedure. Your doctor submits a request. The insurer has 72 hours to respond. In practice, it takes 10 days, sometimes 30. Meanwhile, you wait. Some insurers intentionally lose paperwork. You resubmit. More time passes. By the time approval comes, if it comes, the urgency is gone. Some patients cancel. Some take the cheaper option. Some give up entirely. For chronic conditions, this cycle repeats monthly. Each prior auth is a negotiation. Each delay is a pressure point. This isn't explicitly denying care. It's delaying care until you're desperate enough to accept suboptimal treatment or forgo it entirely. Sometimes the insurer just says no. Not medically necessary, experimental treatment, outside scope of plan. The definition of medically necessary is written by the insurer, not by medicine. A procedure that 10 out of 10 physicians recommend can be deemed not medically necessary by an algorithm. Here's the shocking part. 57% of Medicare Advantage denials are eventually overturned on appeal. This means 57% of initial denials were wrong, but insurers make the denials anyway because they know most people won't appeal. Why? Because the appeals process is deliberately complex, takes months, requires documentation, requires physicians to write letters defending their own medical judgment. Most people give up. The insurer keeps the money. When care is finally approved, you pay before the insurer does. Deductibles. You pay the first $2,000 out of pocket. Co-pays. You pay $50 per visit regardless of actual cost. Coinsurance. You pay 20% of total costs. The insurer pays 80%, but you're assuming the risk. If treatment is unexpectedly expensive, you're exposed. The insurer caps their risk at a fixed percentage. You absorb volatility. The insurer locks in predictability. Insurance is tied to employment. Change jobs, lose coverage. You switch plans every year at open enrollment. Each plan has different networks, different formularies, different deductibles. Treatment gets fragmented. Continuity of care suffers. Records are scattered. Patients repeat tests because the new insurer doesn't recognize prior imaging. This fragmentation isn't accidental. It increases transaction costs. It increases patient burden. It gives insurers plausible deniability when something gets missed. Over time, fragmentation becomes the patient's problem. In 2024, the American Medical Association reports that physicians spend more time fighting insurers than treating patients. Prior authorization requests have tripled since 2015. A typical physician office spends 14.6 hours per week on prior authorization. That's nearly 2 full days per week negotiating with insurance companies. Care suffers. Patients wait longer. Insurers extract more. Every year, 650,000 Americans declare bankruptcy due to medical bills. That's 66.5% of all personal bankruptcies. Medical debt is the leading cause of bankruptcy in America. And here's the cruel part. 78% of people who file for medical bankruptcy had insurance. They had insurance, they paid premiums, they followed the rules, and they still got financially destroyed. Why? Because insurance doesn't protect, it extracts. In Q3 2024, United Health Group made $4.3 billion in profits. That's on $13 billion in revenue. A 33% profit margin. Since 2014, the top 7 insurers have made over $500 billion in profits, $500 billion extracted from the sick. Hospitals spend $19.7 billion every year fighting claim denials. That's money that could go to patient care. Instead, it goes to administrative battles with insurance companies, and it's accelerating. In 2024, claim denial rates hit 11.81%, the highest in recent years. Prior authorization denials increased 26% year over year. Denial appeals increased, but approval rates stayed flat, meaning more patients are fighting denials. But insurers are rejecting appeals at the same rate. AI is accelerating the denial process. What used to take days now takes seconds. Algorithms make medical decisions without human review. The system is becoming more extractive, more algorithmic, more dehumanized, and every year it profits more. You think insurance is broken. It's not broken. It's working exactly as designed. Go back to 1929. Blue Cross was invented to protect people. For 15 years it worked. Premiums covered costs. Claims were paid. The mission was care. Then came the 1950s. For-profit insurers entered. Shareholders demanded returns. The mission changed. Then came 1971. Nixon and Ehrlichman had a conversation. The less care they give, the more money they make. The HMO Act passed 2 years later. Then came the 1990s. Data companies like Optum turned prediction into extraction. Medicare was privatized. Then came the 2020s. AI automated denial at scale. Every mechanism, prior authorization, narrow networks, high deductibles, algorithmic rejection, was added to shift cost burden from insurers to patients. Your pain became a variable. Your recovery became discretionary. Your coverage became a promise with exclusions. And the entire architecture was built to make this inevitable. The system counts on your silence. It counts on you accepting premium notices as normal, claim denials as bad luck, and debt collectors as inevitable. Because the moment you see the architecture, the moment you understand that every delay, every denial, every formulary restriction is a deliberate profit mechanism, the trap loses its power. You become dangerous to them. You start asking questions insurance companies never wanted asked. You start reading the fine print they buried. You start comparing what you paid versus what others paid. You start demanding transparency in a system built on opacity. Financial literacy is resistance. Historical awareness is rebellion. If you understand that this system was engineered to fail you, you stop accepting failure as fate. Question every bill. Demand to know what your provider actually negotiated. Find out if your denial can be appealed and appeal it. Because every successful appeal is money the insurer didn't extract. Every question asked is a crack in the facade, and cracks multiplied across millions of patients become fractures. History doesn't repeat in healthcare, but it rhymes with precision. The same mechanism that drained sanatorium patients of their life savings now drains insured families through prior authorizations and narrow networks. The language changed. The leverage stayed the same. The only difference between then and now is whether you see the pattern in time. If this gave you a new insight, hit subscribe. History has the answers, and I will show you where to look.